Hello, everyone, and welcome to our webinar series titled To Immunity and Beyond, which focuses on immunity and infection in donation and transplantation. My name is Erica, and I'll be today's moderator. Firstly, I'd like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for the diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saluto, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant communities. I encourage you to write your land acknowledgement in the chat box. We'd also like to acknowledge CIHR, whose generous support enabled us to host these sessions. Today's sessions will be recorded and posted on our website and YouTube channel. During the presentations, please keep your microphones off. If you do have a question or a comment, you can raise your hand with the raise hand button or simply write it in the comment section. We are pleased to have Dr. Roy Hutchings present his research, Donor Screening and Recipient Prophylaxis on Donor-Derived Bartonellosis in Solid Organ Transplant Recipient. Dr. Hutchings is a fellow in Transplant Infectious Diseases at the University of Alberta. He completed his internal medicine residency at the University of Manitoba, followed by an infectious diseases subspecialty training at the University of Alberta. His clinical and academic interests focus on infections in solid organ transplant recipients, including donor-derived infections, CMV prevention and management, and antimicrobial stewardship. Speaking for myself and hopefully many others, I'm very excited about your presentation. I will now hand it over to you.
Hi, thanks very much. Hi everyone, my name's Roy. I'm going to just share my screen here. All right, can everyone see this?
Yeah, looks good.
Perfect. All right, I'm presenting our work at our center on Bartonellosis in solid organ transplant recipients, and my supervisor is Dr. Dima Kabani. So in terms of disclosures, I have nothing to disclose. Nobody pays me except my fellowship stipend. But I wanted to mention that although we're going to discuss the unexpected transmission of infection through organ transplant from deceased donors, this miraculous gift from these donors has saved lives. I wanted to start the topic with a case. In this case, a 35-year-old male had IgA nephropathy that eventually led to end-stage kidney disease and dialysis. In 2022, he received a kidney transplant from a deceased donor. He received what is standard induction and maintenance immune suppression at our center. Over the next few months, he had 2 admissions to hospital for fever that we were unable to definitively identify the cause of. He did have CMV reactivation that was treated and an acute kidney injury with a biopsy revealing some mild acute cellular rejection that was treated with steroids. And I think we attributed the fever to these initially. And notably, he was born in Somalia and came to Canada in 2019 and lives with his brother here in Edmonton, and did not have any pets, including cats. About 5 months post-transplant, he had another fever. This time he was found to have this rash, which looked like a widely distributed bright red papules, almost like berries. And he had a punch biopsy that revealed superficial dermal vascular proliferation, so angiomatosis, and positive Wharton starry stain, which is specific for Bartonella species. Sure enough, the PCR of the tissue was positive for Bartonella quintana, and he was treated with doxycycline for 3 months and made a complete recovery. But as always, we wondered, could this be donor-derived? So we considered the other recipients of organs from the same donor, and the heart had been given to a recipient who went to Manitoba and didn't receive any follow-up from our center. The lungs had no fever or undiagnosed infectious syndrome. Similarly, the liver. But the last recipient, a 50-year-old man with a combined kidney pancreas transplant, had been having a prolonged fever we attributed to an infection of a surgical wound And he'd been improving, incidentally, with doxycycline given intended for that surgical wound. But he did have this 7 millimeter papule shown in the picture there. He was tested for Bartonella and had a quite highly positive result. He also made a complete recovery with doxycycline that was extended to 3 months. Now, their donor, since the two recipients shared the same infection somewhat soon after transplant, we wondered if this was a chance that the donor had it as well. And reviewing the donor history, they had had a history of incarceration and use of injection drugs, and importantly, a recent history of experiencing homelessness. As we'll discuss, these are associated with Bartonella infection. We tried to retrospectively test any remaining stored blood samples of the donor, but this could not be completed. After this case, we had 5 more cases of bacillary angiomatosis in solid organ transplant recipients over the next year or so at our center. And more cases have been published in Canada and the US in the last few years since then and before then. So this is relatively new emerging infection in SOT. But first I wanted to review, what is Bartonella? Bartonella are gram-negative, rod-shaped bacteria. They're predominantly intracellular. There are a few species pathogenic to humans, but 2 of them in North America we'll talk about today, Bartonella henselae and Bartonella quintana. Now, all pathogenic Bartonella are spread by an arthropod vector. Bartonella henselae causes cat scratch fever, the illness that Ted Nugent warned us all about. It's spread among cats by the feces of fleas, but can be transmitted to humans if in contact with a wound, such as from a cat scratch. Similarly, Bartonella quintana is spread by human body lice. These live in clothing, and when they're hungry, they come out to take a bite in a blood meal from the host's skin. And the Bartonella lives in the digestive tract of the lice. So after a blood meal, the louse will then defecate on skin and with Bartonella bacteria in the feces. And so if you scratch that itchy area and break your skin with the feces there, the Bartonella may enter your bloodstream and start an infection. The infection was given the name trench fever due to outbreaks in soldiers in World War I, but this is an ancient disease with even 2,000-year-old Roman soldier remains showing evidence of infection. In modern times, however, it's seen primarily in patients experiencing overcrowding, poverty, and houselessness, as these patients struggle with body louse infestations and are unable to regularly wash their clothes, and they will often share clothing with one another, which can spread the body lice infestation that then spreads this bacteria. Now, the clinical presentation of these species of Bartonella depend on the immune host response. So, normal immune system, patients with a normal immune system, Bartonella henselae will present typically as cat scratch disease. There are other presentations like neuroretinitis, lymph node microabscesses, sometimes bacteremia. Bartonella quintana, in contrast, more typically presents just as a fever in immunocompetent hosts. Both are causes of fever of unknown origin or culture negative endocarditis. And like syphilis and TB, they can present in many different ways besides what I've described here from many different organ systems. I'm sorry. When someone is moderately immune suppressed, more commonly you see fever of unknown origin and vascular disease like pileosis hepatis in the liver. But in severe immunosuppression, it often presents as a vascular proliferative disease, angiomatosis. And this results in these enlarged blood vessel lesions visible on the skin. And this seems to be a common presentation for this infection in solid organ transplant recipients. We do have some tools to diagnose Bartonellosis when you suspect it. For the most obvious cases, you don't always need a test and can often move to treatment, such as some cases of classic cat scratch disease with a very typical history. But most cases will be less clear and you'll want a confirmatory test. And the best will be a biopsy of affected tissue with histology and PCR for Bartonella. This could be a skin lesion, a valve piece, or a liver biopsy. But in many cases of Bartonellosis, it presents just as a fever without a specific organ manifestation, and don't really have a target to biopsy. And so in these cases, we rely mainly on PCR of blood and serology. However, these are also fraught with some difficulties. Blood PCR is specific, but has variable sensitivity depending on the lab. On average, roughly 50%. And serologic tests are also, they're supportive, but not definitive. So for example, serology tests are non-specific. There's a roughly 5%, depending on the population, baseline seroprevalence of Bartonella. There'll be many patients that simply have a history of Bartonella and show a positive serology, but may not represent the active infection going on. And the serology tests frequently cross-react with other Bartonella species, with Coxiella, with chlamydia, as examples, and many more. And they're not sensitive tests either. So there's a high false negative rate, especially in immunocompromised patients. Interpretation is also a bit challenging, but it matters for the rest of this talk, so I'm going to describe it here. So anything less than 1 in 60, a titer of 1 in 64 is considered negative. A titer of 1 in 64 to 1 and 128 is considered equivocal. And only if it's 256 or higher that we consider it strongly suggestive, or if there's a fourfold rise in the titer if you repeat it 2 weeks later. You can also do blood culture. You have to incubate it for a month and even still has very low sensitivity. So it's not very commonly used. So who's at risk of Bartonella? Well, both species are found all around the world, including Canada. Typically, people most at risk of Bartonella henselae infection are cat owners. And before 2012 or so, all reported Bartonellosis cases in solid organ transplant recipients were Bartonella henselae, typically amongst cat owners. And in modern times, those at risk of Bartonella quintana infection are those with body lice infestation on their clothing. So this includes people experiencing overcrowding in refugee camps, poverty, houselessness, and otherwise lack of access to water and laundry. The incidence of Bartonella quintana infection among Canadians is increasing. And for example, a recent study looking at cases during the 2010s in Manitoba found 11 cases, and most were patients experiencing unstable housing or lack of running water to do laundry. The true incidence is likely much higher amongst those that aren't presenting to care. And this is talking about the general population. Among solid organ transplant recipients, the primary source of Bartonella quintana infection appears to be donor-derived. We're going to talk about that. Since 2021, there's been a number of case series describing Bartonella quintana in solid organ transplant. All of these were unexpected, and most of which the donor had evidence of infection retrospectively. I've included the confirmed donor-derived cases here. And with a few cases, 3 recipients in 2021 in the United States from a single donor that retrospectively was Bartonella quintana positive. 1 in Vancouver, again, retrospectively Bartonella quintana positive. In 2022, there were a series of cases from a donor that had experienced houselessness and also was B quintana positive. And most recently at our center here, a series of 6 recipients from 4 donors, all of which had experienced houselessness, and 3 out of 4 of them were able to be tested for Bartonella quintana and were positive. And going forward, I'm going to use the term UDD, or unhoused deceased donor, just as a shorthand to describe deceased organ donors who had experienced houselessness within the last 12 months, as this seems to be the common risk factor amongst these cases. the largest center here is about the largest series comes from our center here in Alberta. As I mentioned, 6 recipients who had all had bacillary angiomatosis with Bartonella quintana. These included recipients of kidneys, kidney, pancreas, and liver. And later, a 7th case in heart was identified. Not but that was after the study was published. There were no cases in lungs, and we think that this was because at our center, all lung transplant recipients receive chronic azithromycin antibiotic therapy to prevent chronic lung allograft dysfunction. And azithromycin as an antibiotic has activity against Bartonella as well. Um, Now, these 6 recipients had organs donated to them from 4 unhoused deceased donors, 3 of which tested positive for Bartonella quintana, and 1 was unable to be tested. During this period in total, they had 32 unhoused deceased donors. 11 in total tested positive for Bartonella by serology. These were all tested retrospectively. And that's a 34% seroprevalence for Bartonella quintana in this population, which is quite high. Based on this, they were able to calculate an attack rate of 12.5%. All were treated with doxycycline for 3 months and made a complete recovery. I've shown here the serology results of those donors whose recipients had developed infection, because it's important to note that the serologic titer was quite low for half the donors. As you can see, donor 3 and 4 here had a titer of 1 in 64, which we would typically consider to be equivocal. Normally we would consider 1 in 256 or a 4-fold rise over time to be strongly supportive of active infection. I mean, we could not do a subsequent test 2 weeks later. So how can we prevent infection? Our center developed a protocol in 2023 that, and I've shown the protocol here. It's a little bit confusing when I first learned it, but I wanted to try to explain it here. So in September 1st of 2023, all unhoused deceased donors were tested prospectively for Bartonella henselae and Bartonella quintana. So BHISA-B for Bartonella henselae and BQ represents Bartonella quintana. And if the serology was positive, the recipients would receive doxycycline prophylaxis for 3 months. And that's only for non-lung recipients, as we had no lung cases and they were getting azithromycin anyway. Additionally, they would get prophylaxis if the donor was negative, but other recipients from that donor had developed infection. At the same time in September, we also started doing serology tests for Bartonella, henselae, and quintana for all recipients of unhoused deceased donor organs at 3, 6, and 12 months post-transplant, though this was descriptive and this did not impact prophylaxis. And lastly, starting in December of 2024, we also added on PCR for Bartonella, henselae, and quintana of blood to the donor testing, in addition to serology and above. And we would also have prophylaxed those that were PCR positive, prophylaxed recipients if the donor was PCR positive. And so the purpose of our most recent study that I'm going to be describing here was to describe the impact of this protocol on the incidence of donor-derived Bartonellosis. And so our hypothesis was that that hasn't gone away. Bartonellosis is still prevalent among unhoused deceased donors, and transmission to recipients is still occurring, but that our doxycycline prophylaxis protocol should prevent clinical disease from developing. So our design it's a single center study and retrospective. It included all unhoused deceased donors in Alberta and all of their adult solid organ recipients. We excluded those the donors that had their surgery performed outside of Alberta, and if neither the donor or any of the recipients received any testing for whatever reason, then we also excluded those from the study. The outcomes we were looking at was primarily the recipient cases, and this included clinical cases or PCR positive. Now, clinical cases is what we were primarily looking at. We did not systematically test all recipients with PCR, as you saw in the protocol. Only donors got PCR testing. However, the testing a recipient for PCR to try and diagnose an infection or for whatever other reasons was left up to the treating physician. It's quite expensive to do PCR on all, and we could not do that on everybody. But if it was positive, we did include them as a case, even if there was no clinical disease. We were comparing the pre-protocol cases, which was retrospective, versus the post-protocol cases, which was prospective. Similarly, we also compared the seroprevalence amongst donors, both pre-protocol and post-protocol. We described the PCR prevalence as well, which is only done post-protocol after December. And we described the adherence to doxycycline prophylaxis and the results of the recipient follow-up testing. Now, we used, for donor seroprevalence, we used 1 in 64 as a cutoff because, as I had shown earlier, in the prior study, half the donors whose recipients had infection had a low serologic titer. And so we wanted to make sure that we included, we're over-inclusive in prophylaxing recipients. In the recipient follow-up testing, we use a cutoff of 1 in 128, again, which is lower than the standard 256. And this is because we know that that serology has a lower sensitivity after solid organ transplant, and we want it to be, again, a bit over-inclusive, and lowered that threshold by dilution. So there were 81 unhoused deceased donors during our time period. 4 were excluded because they did not have any recipients. And 1 was excluded because the donor at the time of the study did not have testing completed, nor any of the recipients. That left us with 76 unhoused donors with their 193 recipients. In terms of the organs that recipients received, kidney was, as expected, the most common, with a fairly large number as well of liver, lungs, and heart. A few kidney, pancreas, islet, and heart liver recipients as well. So we're going to start by looking at the donors. There were 27 of those 76 donors, or 36% overall, pre and post, that were seropositive for Bartonella henselae or Quintana, which is pretty high and similar to the previous study. Pre-protocol, that's 52%, and post-protocol, that's 29%, which shows that it's still quite prevalent in the post-protocol period. On the right, you can see the distribution of those Bartonella henselae and Quintana serologic titer results amongst the unhoused deceased donors. So the titer distribution is represented by bar graphs with Quintana on the top and henselae on the side. And then a heat map in the middle that shows the concordance between the two serologic titers. And so what you can see is that there is quite a bit of concordance between the results for Bartonella henselae and Quintana, especially as the titer increases, suggesting that there is probably a lot of cross-reactivity between the two tests. And the reason we make that conclusion is that the risk factors for obtaining Bartonella Quintana and Bartonella henselae are entirely different. And so we would not expect that a patient would have both infections at the same time. Next, we can look at the DNA testing of the unhoused deceased donors. There was 13 that had testing after that began in December of 2024. And so two of them were positive, leading to 15% positive for Bartonella quintana. And recall that PCR is only about 50% sensitive, at least in immunocompetent patients. None of them were Bartonella henselae positive. Now, among those that were PCR positive, they had high serologic titers, so up to 1 in 512. And amongst those that had negative PCR results, they had lower serologic titers, so 1 in 256 and less, though 1 in 256 is not necessarily low. But I think this supports that high serologic titers are indicating a significant infection and were therefore detectable by blood PCR. Now let's look at the recipients. The adherence to at least initiating doxycycline prophylaxis was quite high. 37 out of the 38 in whom doxycycline was recommended initiated their doxycycline prophylaxis. I don't have data on whether they finished their prophylaxis. And of course, in the pre-protocol period, before the protocol, nobody had doxycycline initiated for prophylaxis. Um, looking at the cases. So before the protocol, there were a total of 7 clinical cases, plus 1 additional case that was asymptomatic, but tested positive by blood PCR. Post-protocol, there were no clinical cases, and 4 asymptomatic recipients that had happened to have testing of their blood for PCR. And in most case, in these the single pre-protocol case that had PCR testing was because another recipient from the same donor uh, had clinical disease. In the post-protocol period, those 4 clinician-initiated PCR tests were done because the donor was either PCR positive or very high serology, and in all 4 cases, they were tested right before doxycycline prophylaxis was initiated, and they all took their doxycycline prophylaxis or initiated it and never developed clinical disease. So what I take away from this is that Bartonella is still being transmitted in the post-protocol period, but patients taking prophylaxis aren't developing disease even though they were PCR positive before prophylaxis. Now, those 4 transmitting donors, one had a serologic titer of 512 and a positive BQ PCR. The other had a BQ serologic titer of 256 and a negative BQ PCR. Both donors whose recipients had infection had BQ serologic titers 4-fold higher than their Bartonella henselae titer, unlike all other donors in the post-protocol period. So in the future, I wonder, this would be tested in a future study, be interesting to test whether that is a way to interpret the serology in donors. Now, in terms of looking at the recipient serologies over time in the post-protocol period, I should note here that both Bartonella henselae and Quintana serologies are tested, given their cross-reactivity, and the higher one was used. Not all recipients did serology at each time point, but 91% did at least one time point serology. And so this is a prevalence, the results here are prevalence at each time point. They're not cumulative as time goes on. Most importantly, nearly 90% of recipients of unhoused deceased donors had no serology develop against Bartonella, no evidence of exposure. But a somewhat high proportion developed a low-level serology, at least 1 in 64 titer. And we know that this low-level serology is of unclear significance in immunocompetent patients. Serology 1 in 128 and higher, which we had considered positive, occurred in 2% of recipients at 3 months, 4% at 6 months, and 6% at 12 months. We don't really know what this means, to be honest. None of them developed disease, and we don't have serologic follow-up in the pre-protocol period where we saw the clinical cases to correlate serologic results with who would have developed disease. And what's interesting is that in the 4 recipients that happened to be tested for Bartonella quintana PCR right before and were positive right before receiving prophylaxis, none of them developed positive serology throughout the follow-up period. They all remained seronegative. And so, this I think puts some doubt into the sensitivity of serologic testing in these transplant recipients when they receive prophylaxis. Okay. We decided to report an attack rate here um, where we included a recipient that had any serology 1 in 28 positive at any time, or any PCR positive. And also, I'm sorry, it's got shifted here, but over all recipients that were exposed, so all recipients from a donor that tested positive. And we found with this 13 out of 76, or 17% recipients of seropositive UDD organs developed what we would consider evidence of an infection. So either PCR positive clinical disease or any serology above 1 to 128. Okay, now I'm showing you here the distribution of serology results at each time point and comparing the recipients of seropositive donors to the recipients of seronegative donors. So exposed and unexposed. So dark gray is a negative test. As you can see, most were negative. Light gray is intermediate, and green is a low level titer of 1 in 64, and orange is a higher titer of 1 in 128 and higher. So for example, at the 3-month mark, the recipients of seronegative donors had a high prevalence of a titer of 1 in 64. In fact, higher than the recipients of seropositive donors. And this is true at all 3 time points, which is interesting. However, the higher serologic titers that we would consider to be more convincing of exposure to infection occur more commonly in the recipients of seropositive donors, as we would expect. So this low level positive 1 in 64 is of unclear significance, especially if it's going to be more positive in those that aren't exposed. Okay, so from all this, we can conclude, in summary, that Bartonella exposure remains common amongst unhoused deceased donors. As you recall, 36% were seropositive and 15% were PCR positive. And there's a high concordance between serologic tests for Bartonella henselae and Quintana, especially when the titers are high. So there's likely cross-reactivity with these tests. Donor screening and recipient prophylaxis, or protocol, did reduce donor-derived Bartonellosis. There were no clinical cases after the prophylaxis protocol. And all the lung cases in our post-protocol period, none of them developed clinical Bartonellosis, despite none of them being prophylaxed. And this is probably because they receive azithromycin. And this low-level 1 in 64 BHBQ serologic titer are quite common recipients, especially if their donors were negative, and so this is of unclear significance. Now, there are a few limitations to this, of course. It's a single center study. It'd be nice to do PCR on all the recipients to properly define um, transmission and determine the significance of the serologic titers. But it's expensive and it limited its use. We could not universally do it. Additionally, the fact that the recipients that tested positive by PCR all had negative serology throughout the follow-up period. So, this serologic test is a bit unclear how to interpret. At least it has very poor sensitivity for exposure. Some of these, positive serologic tests might be passive transfer of antibodies from the donor to recipient rather than transmission of the infection. We can't tell the difference between this. And we did not test Bartonella serology in recipients pre-transplant. So it's possible a lot of these that many of these recipients had antibodies pre-existing their transplant, and it did not represent a new seroconversion after transplant. Okay. For this study as well, I wanted to thank Dr. Bani and Dr. Zelius, as well as the rest of our transplant ID team, Dr. Doucette and Dr. Fernandez and Dr. Severa, and most importantly, Sherry and Sarah, who helped a lot with data acquisition and cleaning. That's all I had. I don't know if anyone have any questions about this.
Yes, so thank you for that excellent presentation. As Dr. Hutchins says, the floor is now open for questions. I'm going to take the opportunity and ask the first one. In both species of Bartonella, I said that wrong, apologies. Are humans the final vector or an accidental host?
Uh, in cats, Bartonella henselae, they're presumably an accidental host, as it'd be difficult for a cat flea to then pick up Bartonella henselae from a human afterwards to continue the cycle. In Bartonella quintana, humans are the host, are the intentional host. I'm sorry, I'm forgetting my terminology, but yeah, they are the host for this infection, and it is spread from human to human through body lice.
Okay, thank you so much. I will ask a second question. So, are there any ethical or clinical tensions when you're discussing donor-derived infections to transplant recipients? Like transplant is still, it saves lives despite the unexpected transmission risk. Like, is there any considerations you need to take or not really?
I'm sorry, can you
Are there any,
elaborate?
like when you're discussing this with the patient,
Hmm.
is there any ethical or clinical tensions usually that arise?
I mean, I must say I'm not the one discussing at the time of transplant this possibility with recipients, and so I don't have direct experience to say what the response of recipients are and donor families as well. But I would, you know, one thing that I have been thinking about a lot with this particular um, infection is that, we talk a lot about trying to prevent this infection and transmission of this infection to transplant recipients, where, in reality, this infection in all of Canada is somewhat simply, I should say, not necessarily easily, but simply preventable by providing adequate living situation to the people that have this infection, the donors that have, quite miraculously donated their organs and saved lives. This is an infection that's preventable with simply laundry and housing.
Okay, I can ask another one while we wait. I will go up to four people, and then I'm going to call it. So if you have any questions or comments, put them in the chat. Don't be afraid to raise your hand. What protocols should organ procurement organizations and transplant centers have for rapid reporting, notification, coordination management when a donor is later identified as being Bartonella positive?
I think that yeah, this is something that needs to be coordinated. So it's not something that's routinely tested everywhere. Uh, and but perhaps it should be depending on local data. Certainly here, um, when the any donor that has identified through history as being having a recent history of houselessness is tested, and those results are communicated to the recipient's treating team and infectious disease staff. It does need to be organized, right? This needs to be a system in place. And so, in order to implement this strategy, you have to have a system that can um, consistently and reliably report the results to those who can take action in then implementing preventive antibiotics. What kind of testing is done and who should be tested, I think depends on the uh, what your local epidemiology is, as well as the capabilities and cost for testing in your lab. In our case, we do serology, but because PCR is more expensive, but that might be different at different centers.
Yes, Dima?
Um, Thank you. That was a great presentation. I'm just going to add to the question that you just asked Roy about. So when initially we were seeing those infections, whenever we had disease, so these cases were reported back to GLA, which is Give Life Alberta the Organ program, and these were reported to Health Canada. So whenever we have an infection that is donor transmitted, this is reported back, like clinician would report back to the donor program, and the donor program will notify Health Canada. For the serology positivity, because we don't really know what it means. Health Canada has asked that we don't report back these serology results, but anyone that develops disease, we're still reporting.
Okay, I have a final question. Should unusual donor-derived infections, such as the one we spoke about today, change how transplant programs approach donor screening or post-transplant surveillance when routine donor history is limited?
I think it depends on the unusual infection. Um, and that's going to be a, a different answer for a different type of infection and different location and what your local epidemiology is. Um, Obviously, testing everybody for every infection is would be fantastic if we could do that reliably and cheaply, but that's not reality. And uh, a lot of these tests as well are not very accurate in even amongst deceased donors. So they'll depend a lot on the infection. In the case of Bartonella, this is a situation where the prevalence amongst unhoused deceased donors, which are, an increasing proportion of uh, those that are donating organs after death, the prevalence amongst that pool is quite high, and the there's we were seeing quite a few cases, this cluster afterwards, and so it makes sense to test and prophylax recipients, but that might not be um, feasible if it were a different infection that were either more rare and unexpected, or that had unreliable testing. Like an example might be tuberculosis, where testing is not that helpful in a deceased donor. Instead, utilizing to the best of our knowledge, the risk factors of the recipient of the donor to determine who is at risk.
Thank you. We have
Does
a
that
question.
kind of answer your question?
It does actually. Yeah, it does. No, it does answer my question. Yes.
Okay, good.
Thank you. We have a question in the chat. So this comes from George. He says, great job. So out of curiosity, are there any experimental approaches being explored to treat infection donor organ prior to transplantation? I'm wondering whether strategies similar to those used to reduce viral infections during ex vivo lung perfusion could eventually be applied to this context.
Oh, that's a great question. Very cool. I actually have no idea, to be honest. I don't know. Certainly, I don't know any when it comes to Bartonella. I think this is Bartonella in solid organ transplant as a as something to try to anticipate is relatively new, and so I'm not aware of any experimental approaches to treat donors. Knowing, however, that and yeah, the treatment for Bartonella, to completely treat it, we think is 3 months, and that's hard to do in a deceased donor whose organ needs to be transplanted relatively soon. We could not really wait for 3 months to treat that, and in this case, transplanting them and treating the recipient appears to be very effective. It's an interesting question, though. I don't know.
Okay, on that excellent question, I'm going to be thanking Dr. Hutchings on behalf of CDTRP. Thank you so much for presenting. If anyone has any additional questions, comments, or suggested speaker topics, please reach out to me at ekcroft@cdtrp.ca. Thank you everyone for joining, and we hope to see you for our next presentation on May 28th. Enjoy the rest of your day, and thank you again, Dr. Hutchings.
Thanks very much.